Bismillahirrahmanirrahim. Assalamu alaikum, all of you. I have been listening to some of these talks since morning, and they were very interesting. Well, I think, I have been listening to some of these talks. It's been an interesting and informative session. And a lot of my, headaches have been resolved because a lot of speakers have said, what I should have said on, chronic daily headaches. So I will not repeat them. So just for repetition, it's a descriptive term for headaches that can happen for at least 15 days per month for 3 or 4 consecutive months. And it can include, many conditions like Dr. Manjit has already alluded to. And these are some of the, headaches that can be classified as chronic daily headaches by the same definition, at least 15 days per month for 3 or more consecutive months. It has its clinical and therapeutic relevance, and every diagnosis has its criteria and a relevance. So we've talked about chronic migraines, chronic tension type headaches, hemicrania continua, new daily persistent headaches and their definitions, and so on. And the secondary headache disorders that can also be, chronic daily headaches, and especially, giant cell arteritis. And I remember missing out on a few cases earlier on because, we considered them as to be, due to primary headaches. Cerebral venous thrombosis headaches, of course, a bit severe, but yet they can be missed. It will not be possible to discuss all of these, and they were already being discussed. So we go straight to medication overuse headache. So a chronic headache occurring more than 15 days a month after the regular use of anti-headache medication, and it disappears after withdrawal therapy. So I think that's important because it disappears after withdrawal therapy, and therapy is something that is essential for that particular headache. So the problem with medication overuse headache is that we are talking of a headache that is responsive to the treatment, and it is just causing a headache. And this is why it is missed so often. So what are the clinical features? How do you make a diagnosis of chronic medication overuse headache in a patient who already has headaches? So you see, the diagnosis of medication overuse headaches can be made only in that patient who has headaches earlier on. So headaches occur in a patient with a primary headache disorder who uses immediate relief medications very frequently, often in excessive quantities. Headaches are refractory daily or near daily. The headache itself varies in severity, in type, and location from time to time. And the threshold for the pain is low. A patient of migraine can tolerate headaches. But when it comes to medication overuse headaches, even the slightest stimulus may bring about the headaches. And then over a period of time, you notice that the need for medications goes up, and it goes up, and it goes up. Most of these patients have been taking, only analgesics or over-the-counter medications to treat the acute headaches. But if you start prophylactic treatment in these patients, the prophylactic treatment does not work. As long as the patient is taking those medications that are responsible for the headache, prophylactic medications don't work as well. The moment you stop these acute medications, the patient gets very severe headaches. Think of drug addiction. Drug addiction is something like this. The patient continues to take that addicting drug, and when he tries to withdraw, he gets withdrawal symptoms. It is something similar. Withdrawal symptoms occur when patients are taken off medications abruptly. But then, over a period of days or a maximum of 2 weeks, there is improvement of headaches that occurs on discontinuation of medications. These are some of the associated symptoms: asthenia, nausea, GI symptoms, anxiety, and so on, memory, some claim of cognitive dysfunction, although that is not very, very established. But these are some of the features that can occur, and that makes you, a lot of these patients end up in the psychiatric clinic because of some of these symptoms. But if you have the history of drug abuse very clear, the diagnosis becomes easy. Well, it is not a common headache as noted epidemiologically, but I believe for some reason, I think the incidence of medication overuse headaches in Pakistan is slightly high, although we do not have the statistics, because some of these medications are easily available. You can get these paracetamols and these medications, at any store, go to any panwala, he's going to have some, Calpol and all with him. And that becomes a problem. In specialty clinics, we have, a higher incidence, obviously. In some centers have reported up to 70%. Now, this is the problem with medication overuse headaches because it takes a while for it to develop. Patients on analgesics can have headaches for up to 5 years, before they develop medication overuse headaches. The diagnosis can be missed for as long as 10 years. Ergots and triptans have a faster rate of onset if they are abused. Migraine by far is the most common, headache which leads to medication overuse headaches with the treatment of by the treatment of painkillers and acute pain medications. Tension type headaches generally go on for a long time before they develop medication overuse headaches. So migraine is the most common cause headache that leads to medication if the medication is abused. Again, more common in females, the same ratio approximately as migraines. And, patients have taken up to 25 tablets a day. And the average, number of tablets taken per day is 4.9. Now, this is very, very, high as compared to the standard recommendations that we'll come to later. Okay. Now, it takes about up to 10 years for the headaches to develop in some patients. So you should have a high index of suspicion. So what are the problems in making a diagnosis of migraine headaches? The problem is that patient already has a headache disorder. And the headache disorder is responding to medication. Even if the patient has medication overuse headache, if he takes that analgesic medication, the headache goes away. So a lot of these patients don't leave the house without carrying, a strip or two of their favorite analgesic. It could be paracetamol, it could be naproxen, it could be anything. And the moment they take the headache medication, the headache resolves. But then it comes back and then it resolves. And then over a period of time, the need for medication goes on increasing. Transition to medication overuse headache is gradual over years. And unfortunately, there are no diagnostic tests. You talk to the patient about stopping treatment, he is not going to stop it because he knows that unless, he takes the medication, his headache is not going to get resolved. And we tell him just the reverse. You stop medications and you're going to have a resolution of your headaches, or at least the headaches will go down. So the long-term side effects are very obvious of all of these medications. Renal symptoms, GI toxicity, ergotism, which fortunately now is very, very, low. And over a period of time, these headaches get worse. So what causes medication overuse headaches? Well, in some respects, think of drug addiction. But we are not very clear about what causes it. Genetic predisposition is one factor that is considered. Now, interestingly, if a person is taking naproxen or paracetamol or anything for conditions like, backache or pain elsewhere in the body, he is not going to develop medication overuse headaches. He is not going to develop headaches. So there could be a genetic predisposition because we know that migraine is also a genetically mediated disorder. A number of factors play a part, but genetics is an important factor. So genetic predisposition could be one factor. Then serotonin, down regulation of serotonin receptors. Now, patients who have been regularly using these medications, abortive medications, have been shown to have reduced serotonin in their platelets as compared to those who do not. And then the serotonin receptors on the platelet membranes increase, and that makes the need for, abortive medications higher and higher and higher. So serotonin hypofunction, more headaches, more, serotonin receptors, more need for medications, and that becomes a vicious cycle. And that goes on, and the patient continues to take medications and continues to have headaches. Psychological and behavioral mechanisms have also been talked about, but not very clear. Some patients who are, very, very nervous about their headaches and they want their headaches to go away completely will end up taking a whole lot of medication, as we know. and these people have a higher chance of getting medication overuse headaches. Well, some of these medications like, codeine and opioids have a tendency for dependency. Fortunately, we do not have that incidence as high in Pakistan, but in the West, where I am now, I think this was a major problem a few years ago, and this opioids, epidemic, spread like crazy, and now some of these drug companies are, facing cases. Barbiturates, another thing, caffeine, another thing. I mean, we all know that the more caffeine is actually an anti-migraine medication also. The more caffeine you take, the more you'd like to take. And if you don't take caffeine, you sometimes get headaches. We see this commonly in the month of Ramadan, where all of a sudden you stop medications, caffeine, and it happens. But fortunately, the effect lasts only for a few days. So differential diagnosis, again, is what was elaborated in the earlier talk also. Chronic migraine, tension type headaches, hemicrania continua. So you need to have those diagnostic criteria, and you need to be sure that you're not in any of these categories. Of course, I mean, if you have the history of medication overuse for more than 3 months, then you are safe in making a diagnosis of medication overuse headaches on top of a patient who has any primary headache disorder. Now, treatment strategy. How do you withdraw the medication? First of all, it takes a long time to convince the patient that he has to stop medications. Now, with simple analgesics and triptans, you can stop the medication immediately. Or, if the patient is on opiates or any other, addicting drugs like barbiturates, which we don't use so commonly, then you got to be slow because of other associated side effects. The patient always gets worse before he starts improving. And this is something that you have to warn the patient about. Okay? Most of the patients are okay in treatment on an outpatient basis. Very few patients need treatment on an inpatient basis. So far, over the last 10 years, I have not encountered any patient who has required an inpatient treatment. But it needs a lot of determination. Half the patients, back out because they are unable to tolerate the initial worsening of headaches. So, ergots, triptans, and non-opioid drugs should be stopped abruptly. But opioids, barbiturates, and others should take a while. And sometimes these patients need to be admitted for management because they can get very severe withdrawal symptoms. So now what happens when you withdraw the patient's treatment? See, the important thing is if the patient, say, for example, is on paracetamol or naproxen, the important thing is to withdraw it immediately and completely. Don't gradually go down. And then 70% of the patients do get worse initially. We'll discuss about how to manage them. And they'll get withdrawal symptoms, nausea, vomiting, sleep disturbances, autonomic symptoms, and so on. But then within 4 to 11 days, the majority of them, most of them, improve. And those who have been, on triptans and ergots, they improve faster, okay, than those who have been on analgesics and combination analgesics. So the important thing is that you got to reassure them that over a period of 11 to 14 days, most of the headaches will start going down. And this is what happens in practice. We have very few patients who are on only ergots or triptans. So most of the patients take a while. In my experience, I think it's been 7 to 14 days, and they start feeling better. When I say they start feeling better, it means that the medication overuse headaches, has started subsiding, but the primary headache disorder continues. In other words, if they've had migraines once a week or once every 2 weeks, that does not go. But the daily headache that has occurred as a result of medications is better over a period of time. And this is your, diagnostic, test of medication overuse headache. So how do you manage the withdrawal symptoms? You have all of these features: headaches, vomiting, arterial hypotension, tachycardia, seizures, sometimes hallucinations, but all of them are generally improving over a period of maximum of 2 weeks. But some patients improve pretty fast. You may need to give supportive treatment, IV fluids, but again, that is required in opioid toxicity and those. Now, judicious use of analgesics and tranquilizers is recommended. For example, if the patient has been only on, say, paracetamol or naproxen, then you can carefully use triptans to take care of the headaches in the acute phase. You can use ergots, and there are some new drugs which we'll talk about. Another theory is that another practice is that if you are making a diagnosis of medication overuse headaches, sometimes it's better to start a patient on a prophylactic and expect that the intensity and frequency of the headaches would go down before you start reducing medications. But this is not accepted because prophylactic medications don't work as well in a patient who has such headache disorders. Some centers have used a short course of steroids that seems to work in very severe symptoms. One treatment that works pretty well in almost 40% of patients is the use of Botox. So you inject Botox and then start withdrawing, the patient from treatment. And these patients have less of withdrawal symptoms. But I mean, given the cost and all, and the fact that all of these symptoms are going to last only for 2 weeks, makes the use of Botox expensive in such a situation. Now there are some new drugs that have come in the market, and these are the GPANs and DTANs and CGRP molecules that are used in migraine prophylaxis. Now CGRP monoclonal antibodies like erinumab, the amigovig, and galactinumab are used for migraine prophylaxis. But there are smaller compounds, CGRP antagonists, non-peptide small molecules that can be used in acute migraines. Now these are good because they give you instant pain relief and no tolerance has developed. Well, I think it's not developed so far. Probably if you start using it too often, it may happen. And there are some of these drugs. We don't have them, but at least rimegepant used to be available, through some pharmacies if you order it. Expensive, but good. I don't know what the situation is now because I think things are still tightened. But you can give these, to these patients. In fact, these are also good medications in the treatment of acute migraines, even otherwise, without the medication overuse headaches. And, they seem to be working pretty well. And then you have DTANs, which is just improvement over, sumatriptan and triptans. These are 5-HT1 receptor agonists, unlike triptans that are 5-HT1B and D, agonists. These don't cause vasoconstriction, so they are safe in cardiac patients. So I was attending a headache conference recently in Minneapolis, and all the talks were on these medications, CGRPs, GPANs, and DTANs, and all of those. And no one ever talked about amitriptyline, topiramate, and naproxen, and so on. So that's the trend. But I think we have to be in this country careful. But the point is that in the acute patients, in bad patients with severe symptoms, these are some of the possibilities that you should be aware of. And hopefully, we may get some of these soon. I was talking to some representatives of the pharmaceutical industry, and they are looking at it. Let's hope we get something, at least for those patients who do not have any resolution with existing medications. Well, the prognosis is good generally. Mean success rate, of withdrawal therapy is almost, 70%. And success rate is defined as no headaches at all and an improvement in the medication or use headaches of more than 50%. Of course, the patients will get their old migraines back. I have a patient who started to have migraines again at the end of, every month. And that was a, earlier frequency. Some patients have it once every week or once in 2 weeks. So they go back to the original migraines. Well, a relapse rate has been found, at the rate of 40%. And, at the end of 4 years is, 42%. And one of the main reasons cited is that, these patients again end up starting, to have those acute medications. And, some of them develop headaches, probably because there could be a genetic predisposition for some of these patients to develop headaches more frequently with some of these medications. Factors influencing relapse rate. Patients with tension type headaches somehow, behave in a, much better as compared to those patients who have migraines. All right. If the patient is using combination medications, then, okay, there are greater relapses. The patient is using a single medication, it's less. Unfortunately, most of our patients end up using multiple medications. Then other factors like, stress and those things can, also be responsible. So finally, what are the prevention guidelines? For all of us, a careful and judicious use of acute medications for all types of chronic headaches. And the recommendation by NICE as well as the American Headache Society, and I think even the International Headache Society, don't, recommend analgesics to be taken more than 2 times per week. We know that this rule is not generally followed. So maybe 2 to 3 times, but anything more than that, I think you better start off with prophylactics and try to reduce the incidence of acute migraines or headaches. The same restriction applies to ergots, triptans, and so on. Combination medications work well, but then, they create more problems. So, avoid combination medications like those containing caffeine. We have one paracetamol plus caffeine preparation available. Fortunately, the others are not available in combination in Pakistan. Maintenance of a headache diary, of course, for all headaches is important. And early use of prophylactic therapy is something that is, recommended. Anyone who has more than 3 to 4 headaches a month, depending upon the kind of severity of every headache, is a candidate for prophylactic therapy. And the earlier you start prophylactic therapy, the lesser these patients are likely to get medication overuse headaches. Thank you.